Glad to be back. I'm just going to speak from notes instead of giving you slides, and I really would be happy to take questions. So I'll be sure to leave enough time for that. Just like I'm getting a stopwatch out here so I know how long I'm going. They asked me to speak here about the future of quality measurement programs. So I'll kind of go through from starting at the high level, the strategic vision and the what I've been seeing across the country, and then get into some specifics that I think are really terrific emerging practices and things that, as I look at other industries, where I think we might be going. You guys highlighted it really well here at the beginning with Bo's talk about what MIHIN's goals are. Everyone is focused on why are we doing this? And the why we're doing this is to make patients' lives better, to get people healthier, to make sure we're spending our money in the right place, and to be sure that we're not overlooking and missing problems. So I always think about, I only want to collect data that is going to lead to action, and only want to collect data that's going to lead to the action at the right place at the right time. So in my time working at the health system, I was asked to build a health services research data institute. It was really fun. My chair got me a whole bunch of money and a really terrific PhD biostatistician and access to Medicaid claims from the state, public health data from the county, and our whole set of EHR data. And we worked for 3 or 4 years to build this really terrific integrated data set. However, we were unsuccessful. And the reason we were unsuccessful is it didn't have a reason. It didn't have a purpose. We could never articulate what were we going to make better, what was the goal, the priority, what was the decision we were going to impact with this data. All these people said, it's going to be fun, it's going to be cool, you're going to be able to now see all this stuff. When we finally actually were able to use our data for something cool was when we had a dramatic change in a state Medicaid program, and we suddenly stood up a new block grant Medicaid program with almost no time. And suddenly all of our inability to execute on a really cool data policy was quickly made possible. And it was all the same people. It was all the same people with the same interests, but suddenly we had a clear goal. What information do we need to know today? What information do we need to know this month? What information do we need to know next month? We had 6 weeks to stand up a complete health plan and ACO program for 9,000 Medicaid beneficiaries. And that rapidly drove our analytics and our analytics plan, and we could use the data and information in really effective ways. And I've seen this over and over again where people have grand visions of what their data reporting, what might they possibly do if they could get all this data, and you get kind of a flabby, inaccurate data infrastructure because no one's really paying any attention to the details. They're just hoping that someday, sometime, we'll use all this data to do something that we have not yet really articulated. So that's why I really like this model of how do you first start with the point of care, the improvement that the local people want and need to do, that they're interested in and motivated in, and then they will help be sure that data is good because they care about it. And so if there's a push across the state to make sure every kid is immunized, or a push across the state to make sure 1 Million Hearts happens, what does it take for that local clinic to have the information they want and need to make sure that they have managed all of their hypertension patients effectively? And they're then motivated to look at their data, use it, and it turns out through that constant use and feedback, the data is going to get good and it's going to scale really quickly. As opposed to starting at the aggregate level, it's really hard to go from a state level reporting on blood pressure and get down to the data accuracy you need at the local level. So that's number one. The purpose of the data, the purpose of the measurement has to be clear, And we need some kind of accountability, but primarily we're using accountability as a lever, as an action lever to improve patient outcomes. And the patient outcomes are going to be improved in the care delivery system, not with us as the accountability partners. Similar, but not exactly the same, Seema Verma, who's the new administrator for CMS, articulated her four goals that she has for us as an agency. One of those is, I can't remember the exact words, but it's making sure that patients and providers are empowered to make decisions about care. So in the health services research world I come from, that's called shared decision making. And there's a really terrific methodology in how shared decision making works. And how do you make sure that people have the information, both the patient viewable, understandable information and the provider viewable, understandable information, so they can make decisions together? So again, a little story. How many of you have ever heard of the Swedish Rheumatology Registry? So Google it. It is the coolest thing. Nobody has mandated any of the rheumatologists in Sweden use it, yet they almost all do. It is being used because everybody loves it. The way it works is, as a rheumatologist, you sit down with a patient who has rheumatoid arthritis. And those of you that know rheumatoid arthritis, it's a chronic disease. You get a lot of pain. There's a lot of medicine, but the medicines all have side effects. And so you together, as a patient and a doctor, build a care plan around your rheumatoid arthritis and say, for the next 3 months, try taking these medications, and why don't you monitor your daily function and monitor your side effects? And you're given a way to do that. Often you can do it on your phone, or you can do it on a web app, or even on paper. And then you come back into the clinic, and the doctor pulls up your decisions about which meds you took on which day, and pulls up what your symptoms were, both the side effect symptoms and your functional symptoms from your rheumatoid arthritis. And you look at it together and you say, hey, look at this. Over the last 3 months, you took your pain medicines on these days and you had all this dizziness, and your function wasn't any better. And they then compare you to all the other rheumatoid arthritis patients in the country and make a decision about you in context with all the other patients. And then they say, hey, so that's what it looked like last time. What should we do this time? And so for the next 3 months, you modify your joint care plan, and together you decide what that should be. And then you as a patient go out again and do the same thing. And you do some quick monitoring of your symptoms and of your side effects. And on an ongoing basis, the two of you have this tool to be able to make shared decisions and to really effectively know what to do. And as a country, they're rapidly growing this very practical information about how to manage rheumatoid arthritis. There's no reason we can't do that for lots and lots and lots of conditions. It's about how do we frame our measurement and our technology around this use that how does it best help people making a decision, empowering patients, and empowering them to make a decision with their provider. Another trend I see in the world of quality reporting programs is decreasing the burden trend. And so the current, so when I was at my health system, we looked at the quality reporting programs we had, and we recognized that for 300 providers, we had 17 full-time FTEs just abstracting data for the purposes of quality reporting. That was a lot of people. They were reading through a lot of charts, and this is now back in the mid-2000s, so hopefully it's different there now. But I would go and watch them. I watched the cancer registry team. And what they did is they had the cancer registry pulled up on the internet over here, and then their electronic health record pulled up over here, and they would just sit and type all day long into the cancer registry while reading everything electronic off of our electronic medical record. And we were paying people to do this, read one computer screen, and just type all day long into another computer screen exactly the same things that were in this computer screen. So we have, I can guarantee, thousands of those people with those jobs all across this country. And the goal of this electronic health record reporting is if we can make that automated, if we can make that one computer talk to the other computer, we can free up thousands of people that instead of retyping people's names and diagnoses can actually go out and be agents of change and quality improvement. And we have examples of that that have happened across the US. I was talking to a hospital that had gone to real-time reporting through their EHR of their hospital immunization quality measures. And what the nurse specialist had said was that they used to get a chart 30 days after discharge, and they would work really hard to prove that the patient had actually gotten the shot. And so they would spend hours digging through the chart and trying to do this work and justify that either the patient didn't really need it or they had it. In the new world, on the first day the patient was admitted to the hospital, they got a report of all the people in the hospital today that didn't have a shot. And instead of spending hours digging through the chart to prove that they either didn't need it or did get it, they just went to the floor and made sure the patient got the shot. And it was done. So those are the kinds of reasons to decrease the burden, not necessarily because it's less costly, although that would also be nice. It's because we can actually free up the capacity to do the kind of work we really want, instead of using that capacity to do this kind of data entry and data transfer in a 19th century clerical person sort of way. That also decreased the cost of reporting. And I'm a little bit of a heretic here, but I frankly think we don't have enough measures. A lot of people think we have too many, and I think we don't have enough. If I think about the complexity of the care I delivered as a primary care doctor, the complexity of the work we did as a health system, to think that with 3 or 4 really good measures we would know that we were doing a great job is really hard to imagine. My health system had 40 different clinics. We had 17 different specialties. The eye doctors, when we talk to them, they tell us they have 6 different key subspecialties, and each of those subspecialties does a lot of activity. They have people that just do retinal surgery. And if we have people that just do retinal surgery in this country, shouldn't we know that their retinal surgery is actually doing a good job, as opposed to measuring them on cataracts that they never ever do? We had an orthopedist who only operated on hands. Does it make sense that the orthopedist that only operates on hands gets measured on their hip and knee surgical outcomes when they don't do any hip and knee surgeries? So if we're gonna face up to the fact that 20% of our economy is actually in the healthcare space, and we really want to move to outcomes instead of paying for activity, I think we're going to need actually a whole raft more measures to make that happen. But the only way we can get there is if they're not so freaking costly to create and maintain and extract. So how is it a much more routine and automated part of the work as opposed to being a heavy lift each and every time? To that end, one of my favorite kind of measure programs is the Ryan White HIV measure program. Do any of you know much about Ryan White reporting? So Ryan White HIV reporting, a few years ago, they came up with what they called the measurement cascade. And the brilliant and beautiful thing about the measurement cascade, so essentially what it does is the measurement cascade is a set of linked measures that are really important to being sure that we have good control of HIV care in the country. And so the first measure in the measurement cascade is how many people don't know about their HIV diagnosis, or they're all put in the positive. It's how many people do know. So what's the percentage of people with HIV that know they have HIV? And the second measure is of the people that know they have HIV, how many of them have been referred to care? And the third measure is how many of the people that have been referred to care are retained in care. And the fourth measure is how many people that are retained in care are on the right medicines. And the last one is of all the people that are on the right medicines, how many have their HIV controlled? So those have a really nice logical interconnection from a consumer point of view. The thing they challenge, but that's been the most exciting, interesting thing to see, is they have a overlapping responsibility between lots of different people. There's no one actor in the system, no public health, providers, payers, no one of those places can make all of that HIV cascade work. A provider doesn't have much control over the number of people in a city who don't know that they have HIV. Providers aren't responsible for screening whole populations because most of them aren't in care, right? On the other hand, public health isn't primarily responsible of making sure that all the people on medicines are on the medicines that actually control their HIV. So when you go to a meeting, Ryan White meeting, where they talk about measures, they have now a common set of, all the public health people and the providers are in the same room, often with the payers and the states, and they have a common way to talk about it, a common way to talk about where they're intervening and how they're intervening, a common way to see across the country which kind of practices are working here and there, all in this same measurement cascade. Imagine if we could build those kinds of measurement cascades, those frameworks for lots of the stuff that we do, and get the right people in the room to have these collaborative conversations that say, hey, we're about all the way from public health to the control and the prevention that we really care about that's only done by the healthcare system. Similarly, you can build those kinds of process measures within a health system. So we did a lot of this at my health system. We would take a measure like A1C control, and that was the outcome measure. But we would maybe build 5 or 10 different process measures within our clinics to make sure we were doing all the things that we knew we had committed to do to be able to hit that measure. So how many times when a person came into clinic that needed an A1C did we order it? That was one of our measures. How often did we do outreach on people whose A1Cs were past due? So we can either ask every single office and practice to build those themselves, or we can think about what's the common set of those sorts of process measures that we can easily make available in the technology for these offices, so they can, again, quickly have the data they need to be able to focus in the right place and not have to spend all their time reinventing a process measure infrastructure that helps them achieve the outcome measure we all care about. So that's some of the goal in things like the quality payment program. We don't explicitly call it out and require it, but the use of clinical decision support, the incentives around the quality improvement initiatives are aimed at that kind of space. And so from the federal standpoint, instead of mandating, we're trying to incentivize and provide tools and infrastructure that would help make that happen. But the more there's a clear vision and a consensus about how to achieve it, I think the better we all are. Some specifics, and I think that I covered some of this in my talk earlier today, but this idea of moving to real-time data as the source away from a retrospective analysis, we have a lot of work to do collectively. We don't quite know what and how we should do that sort of measurement. What does that look like? What would we like it to look like? Because that's the opportunity, but unless we start testing and figuring out what it can be, we're never going to get there. We're going to always be in a retrospective frame, and we'll be frustrated that our new way of getting real-time data doesn't map to our old measures and our old outcomes. On a sort of similar note, because we used to pay people, and still do, to read through charts and then type in things, we treat data as expensive. What do I mean by that? Well, one of my very first measure programs was in inpatient diabetes. And we realized that most of the measures around diabetes had assumed that you would just get a couple of data points. You'd get 2 hemoglobin A1Cs. Well, why did you only get 2? Well, because it cost a lot of money to get each and every one of them. You had to have people read through charts, and you had to read through lots and lots and lots of charts, and it was just really costly. When we looked at inpatient diabetes and tried to figure out a measurement world for that, we found that patients would have hundreds of blood sugar readings in the hospital. And the question was, do we just take 2 of them and say, let's take the first one and the last one and use only those 2? Well, that's not very accurate, actually. We could get a lot better information about how a patient was controlled if we took all 200 of their blood sugars that they had while they were in the hospital and used engineering statistical methods to figure out what the trends were like. So how do we think of those repeated variables as an asset to us as opposed to as a challenge or noise? How do we say if someone has daily blood pressures taken at home by an automated blood pressure cuff, that 365 blood pressures is something that's terrific from a measurement standpoint, and we know how to use it and how to do it and how to tell what that means when we actually measure blood pressure control? Because our current measures are built around this idea of expensive data, get just a couple points in time, and try to ignore the rest. I think we'll hear a little bit more about this later, if I remember correctly, patient-reported outcomes. I'm a huge fan of patient-reported outcomes. We know that this is a key priority for the government. We're working hard to put patient-reported outcomes into a lot of our measure packages and measure programs. What do we mean by patient-reported outcomes? Well, a patient-reported outcome is when the patient, him or herself, tells us that they are better after a treatment than they were before, to put it bluntly. The work in studying and understanding how to do this has been using primarily survey research methods and creating validated questionnaires. Those validated questionnaires range from as little as 2 questions in like the PHQ-2 to 50 or 100 questions in some of the larger measurement sets. But the patient-reported outcomes are much more understandable to consumers. We've done work trying to ask patients what kind of things they want measured and how much do they pay attention to our measures and measure outcomes. They almost never pay attention to what we have because it doesn't mean anything to them. They don't care that they had 2 hemoglobin A1Cs last year. That doesn't map to any measure of quality that they really know or understand. We need to find ways that what we're measuring is actually really useful, meaningful, and understandable to patients, and that patient-reported outcomes are far more understandable to patients than our typical measures that we've been getting. So I think some of the most mature and best examples are the patient-reported outcomes around total hip and total knee replacement surgery. And in these measures, we take typically the industry best practice right now is to take what we call a universal functional measure and a condition-specific functional measure. So for those measures, we take a universal measure of function, and we're using the I'm trying to remember the word for it, but anyway, it's like Promis Global, it's called. It's a 10-item questionnaire about your overall function, and then a condition-specific measure of your function around your knee. How far can you walk upstairs, et cetera, et cetera. And you do that pre-op, and then you wait 6 to 9 months post-op, and you re-measure it. And you look to make sure that people actually got better, that their overall function is better, and that their knee function is better after surgery than before. Those are measures that people really like. And they understand them and can really move to them. And in fact, those types of measures are allowing us to create a whole new kind of market for healthcare. So Virginia Mason Healthcare system in Seattle has invested a lot in the lean methodology of quality improvement and making sure they have a really good, consistent set of care that they can provide. To the point that they actually know within a really narrow band what their rate of complications is and their rate of safety issues and their outcomes. They also then know what their costs are because they've so standardized their care. What they've been able to do is contract directly with some big employers. So for example, Walmart now sends routinely their patients from all over the country to Virginia Mason to get their back surgery because the patient-reported outcomes are consistently good, the costs are consistently known, and the complications are super low. And that lets us have a national market for these things, that we're focused on value of both outcome and cost, as opposed to focusing only on a local market. Another way that we can start leveraging technology and what the rest of the world does to really do measurement in a different way is thinking about how measurement happens on the web. So one of the things that's really exciting to me is the Promis Measure. So these are Patient-Reported Outcome Measurement Information System, PROMIS. This was a $500 million project of the National Institutes of Health to build a whole suite of patient-reported outcomes for use across a lot of domains. They have measures of dementia, they have measures of sexual function, they have measures of emotional function, and measures of physical function, all sorts of measures across lots of domains. It's all free because the government paid for it and it's there, it's all studied, there's a lot of research. One of the things that they have been promoting that I like a lot is called computer adaptive testing. So this is how people now take the SAT test. And so they have a whole bank of all the questions you might possibly get asked. And they ask you a first one that might be kind of middling hard. And if you get it wrong, you get an easier one. And if you get that one wrong, you get an even easier one. And they quickly know which sort of quartile you're likely to fall into. That computer adaptive testing works really, really well for things like functional measures in patient-reported outcomes. So if you can imagine where we have both a 95-year-old frail woman and a 25-year-old marathon runner that we're trying to ask the same functional status measure questions about. We could ask and ask and ask and ask on a really standardized set of questions and never really be able to differentiate improvement in either of them because they're at far ends of the scale. If instead you use a computer adaptive testing model and you ask each of them the first question, can you walk a mile? And the elderly woman says, absolutely not. Can you walk a block? No, I can't. Can you walk 10 feet? All of a sudden you're quickly into her zone of function with just a couple of questions. Similarly to the 25-year-old marathon runner, can you walk a mile? Yes. Can you run a mile? Yes. Can you run a mile in under 7 minutes? Yes. All of a sudden, with 3 questions, you're way up at the high end of the function scale with him. So the whole bank of questions might be 1,000, but any one person will only get a few of them that can very much more effectively differentiate where they are in their functional status. So this exists. They've built this. Promis has it. What's the barrier to using it? People don't think about measures this way. People think about measures as a static set of the exact 5 same survey questions I always ask every person every time in the same way. And we lose the power of our new technology and our new techniques by not leveraging this stuff that's worked in other industries. Finally, where do I see us going? I think, again, what Medicare has been doing, and in part what we're doing with states as well through the Qualified Clinical Data Registry Program, is how can we federate some of this work? How can we make the programs not be one single IRS-like place where we collect and adjudicate everything in a central core, but how do we say we have a diverse and complex healthcare system that we're going to have many different specialties, many different conditions, many different priorities by which we should have places of adjudication. So as I look at the new administration priorities, but also look at what's been really effective in the past, I think we'll continue to see this outsourcing and federation of some of the measure development, the measure aggregation, and also the kind of measure benchmarking of good performance. So the examples in the Qualified Clinical Data Registry program is this is happening in the specialty societies. So rather than CMS creating all of the eye doctor measures for all of the 6 subspecialties, the ophthalmologists have done that, and the ophthalmologists manage it, and the ophthalmologists benchmark it, and the ophthalmologists run the data and give the feedback reports. And they are a federated partner with the US government, and they send us who did well and who didn't do well across those sets of measures, and we have partnered with them to make that happen. That could also happen in a regional level. So where I was born in rural South Dakota is a really different kind of healthcare environment than where I live now in Washington, D.C. You might imagine it might be better for them to create locally the kinds of measures that really make sense for rural South Dakota and benchmark the kind of care and outcomes that they get there that are benchmarked with that local expertise and the local priority, as opposed to benchmarked just solely based on what we care about in Washington. So I think that this federation of the measurement enterprise will continue to happen. My hope is that we have a baseline of standardization and a baseline of infrastructure that is consistent across. And rather than recreating a whole new model in each and every federated node, we say, here's our baseline infrastructure and our baseline way to communicate, and things like demographics and provider MPIs and all that kind of stuff is pretty consistent, so that then we allow the modification and the localization to happen on top of that base set of standardization. It's still an open question in my mind that we'll fully be able to get there, but I have every confidence in the great work of people like you guys that will make it happen. So with that, I'll open it up to questions.
Thank you. That was insightful, and I appreciate the perspective. As I mentioned during the introduction, I represent public health. I'd like to hear your insight and thoughts about where this can take us in terms of, again, addressing health disparities, population health improvement. Would you say a little bit about that?
Absolutely. I had the pleasure to serve on an IOM committee called Vital Signs Core Measures for the country, where we spent 2 years trying to figure out what would be the national set of aligned measures that we would care about for us as a country. And there was a lot of rich back and forth between health delivery and public health in our deliberations, and I think you see it even reflected in the report. Where I worked in a county hospital, we kind of had one foot in public health and one foot in delivery. And what I saw from either side of that is that delivery is so easy to focus just on who's there. We had a hard time ever paying any attention to who wasn't actually there. We felt so busy dealing with all the people that were there. What I noticed about public health is that there was a lot of analysis, and it wasn't always clear what the action arm was going to be for all the analysis. And I have terrific friends in public health, but I sometimes couldn't figure out even that they had a theory of action behind their analysis, that somehow the analysis and the report was the end. So I guess what I would challenge us all to figure out is, how do we think of ourselves as partners in this, much like the HIV community? How do we align together and then get more articulate about who has what lever where, and how are we sure that our data and our infrastructure is really invested and prioritized in getting us information to make a decision at this particular lever. So for example, if you're in the HIV care continuum and you're thinking about number of people screened positive for HIV who've been referred to care. So whose job is that? Well, that's a great conversation to have with a combination of payers, providers, and public health, right? Because you have to have all of that in place in your state. And then you'd want to know, like, once that group starts asking the question, what data do we want? Then you're saying, okay, now let's figure this out. Do we have the capacity? If we have the capacity, then how do we get them there? What's the motivator? Well, maybe that's a health plan motivator. Maybe that's a Medicaid motivator. So by really crisply articulating your theory of change, what you think we're going to do with this, then I think you're much better prepared to work together to solve these problems. That's at least my perspective.
My mind's still trucking along the idea of the ophthalmologist group you were talking about that are handling their benchmarking.
Yep.
If there was another group of specialists, how would they initiate that conversation, and what programs might that apply to?
Well, so the Qualified Clinical Data Registry Program, QCDR, MyHIN is one of those. But if you go to you search online for Qualified Clinical Data Registry, QCDR, you'll see them all listed. And the last I counted, there were like 25 or 30, but there's probably more of them now. Many of them are specialty societies, so many specialty societies already have a QCDR. The emergency room doctors have one, the surgeons have one, the neurologists have one, the dentists are thinking of building one. If there is already one there, they can join in one that already exists. So the family medicine has one. They may even have more than one, actually, in family medicine. If you want to become one, then you look at the CMS website to figure out what it takes to become one. And there's a series of steps you have to go through. You have to go through an application. You have to submit which measures you think you'd be able to do, both measures that are already NQF endorsed and some measures of your own. And if you do measures of your own, you have to submit some data and a data plan for how you'd validate those and how you'd use them. As I was talking to this table up front, what a lot of people don't realize is that there are 2 or 3 health IT analytics vendors that are the behind-the-scenes guts of most of these QCDRs. So if you wanted to do it, what the ophthalmologists and the emergency room doctors and others have done is they've become the consensus group. They figure out the business model. They have the relationships with all the providers. And then they call up one of these vendors that's figured out how to make all the technical part happen. And the vendor comes in and solves the technical part for a price. And the specialty societies are very happy with these technical vendors. They've done a terrific, terrific job of supporting it. And for the ophthalmologists, it's free. It's free as long as they belong to their academy. And the academy supplies it as part of the offerings of the academy. Other questions?
All right, any other questions? This is Dr. Larsen's last shot. So.
I didn't comment on Medicaid. I'm happy to talk a little bit about Medicaid. As many of you know, in last year's Medicaid Managed Care Rule, there was a requirement for a quality reporting system, a QRS, that would be part of any state's Medicaid Managed Care programs that meet a certain threshold of risk-based payment. So the details of that we're still working through. One of the fun things we've embarked on at CMS is a user-centered design project where we're actually interviewing Medicaid beneficiaries to understand how they make decisions about Medicaid managed care plans and what impact quality has in that and what impact they would like quality to have in that and what their view of quality is when they're making a decision about which managed care plan that they have. We don't really have any outcomes from that user-centered design activity yet, other than to say that in our initial work, quality was not high in the list of the things that people were using to choose a Medicaid managed care plan. They were looking at reputation and convenience and familiarity and things like out-of-pocket expenses. But there is a whole set of robust work in the Medicaid measurement enterprise, and if anyone wants some connections to that, I'm happy to connect you. There's a new chief quality officer in Medicaid at CMS who's really fantastic, and was the chief innovation officer for healthcare in Maryland for a number of years. She actually wrote the Meaningful Use Act when she was working on the Hill. So she's got a deep knowledge of health IT and a deep knowledge of what it takes for a state to kind of stand up a state-based quality reporting program. Thank you much. It's terrific to be here again, and look forward to the rest of the afternoon.
Thank you, Dr. Larsen.